Hello, everyone. Thank you very much for participating in this session. We have a very exciting session named Most Challenging Valve Case This Year. My name is Dr. Nobuo Komiyama of St. Luke's International Hospital in Tokyo, Japan. We have other moderators, Dr. Chen from Korea, and we have 6 discussants, Dr. An, Dr. Khan, Dr. Kaur, Dr. Lee, Dr. Park, and Dr. Young. So I'm going to introduce the first presenter. The first presenter is Dr. Nishan Gangil from UK. His paper will be transcatheter aortic valve implantation in rheumatic severe aortic stenosis in presence of mechanical mitral valve prosthesis. Dr. Gangil, please start your lecture.
Warm morning from UK. Hope the weather there is sunny as well. Sorry for my appearance, but it's early morning. I literally woke up 15 minutes ago. Anyways, many thanks for accepting our case for this presentation. So it's a case of transfemoral Tavi in case of severe rheumatic aortic stenosis with pre-existing mechanical mitral prosthesis. I'm a consultant cardiologist in NHS Trust. These are my disclosures. So my patient is a 58-year-old lady who had previous mechanical mitral valve implantation in '92 for severe mitral stenosis, and this was a single leaflet tilting disc valve. We didn't have any operative notes, and she now presented with severe rheumatic aortic stenosis and was in NYHA function class 2/3 with no major previous medical history other than the open heart surgery. And in view of this previous valve replacement, she was considered for Tavi as per the MDT consensus. So these were the preliminary investigations. The ECG showed atrial fibrillation with baseline right bundle branch block. The chest X-ray on the right side of the screen shows slightly increased CT ratio with cephalization of upper lobe veins and mechanical mitral prosthesis in situ. Her transthoracic echo showed she had a tri-leaflet aortic valve, which was non-calcific with commissural fusion. The peak gradient was 70 with mean of 40 across the aortic valve, but she also had underlying severe LV dysfunction with ejection fraction of approximately 30% and moderate pulmonary hypertension. The mitral prosthesis was working well. And like all Tavi patients, the standard practice is to do a CT scan. So the image in the center shows, again, confirms the findings of echocardiogram, whereby it shows that the valve is not calcific. The Agatston score of this valve is 30, but the leaflets were extremely thickened and fibrotic. The image on the left side of the screen shows the mechanical mitral valve prosthesis along with thickened aortic valve leaflets. And the image on the right side of the screen shows the aortomitral distance, which was around 8 millimeter in her case. Just in brief, this distance is the lowest most point of the left coronary cusp to the top margin or the uppermost margin of the mechanical prosthesis. The valve area on this CT scan was 505 millimeters square with perimeter of 84 millimeters. The sinuses were good and capacious. The coronary height was all unremarkable. Now, this is the initial aortogram, and then I'll go further. So you can see that on left side, it's a coplanar aortogram. So people who implant balloon expandable valves would be quite familiar with this. Whereas the aortogram on the right side shows the cusp overlay view, which is important for mechanical, self-expanding prosthesis. You can also see the mechanical mitral valve with the leaflet moving fairly well in both these aortograms. So before I move forward, there are a few important aspects in this case, and I'll go through them sequentially. So in her case, the first question was whether we should go for a balloon expandable prosthesis or a self-expandable valve. Now, in her case, since the calcium score was quite low, this would traditionally favor a balloon expandable valve because you can overstretch these valves, overexpand these valves to get better anchorage. In fact, there are now numerous case reports which have suggested using a balloon expandable valve for non-calcific aortic valves with isolated aortic regurgitation. And therefore, in her case, this would favor a balloon expandable prosthesis. But one must also remember that she had mechanical mitral valve, and therefore recapturability of TAVI system would be extremely helpful. And since her aortic annulus was well within the reach of the TAVI valves, we felt that overstretching would not be required, and therefore we decided to go with Medtronic self-expanding Evolute Pro system. Once the type of valve was decided, the next question was to size this TAVI prosthesis. Now, this was rheumatic aortic stenosis, and in my experience, these valves behave very much like true bicuspid valves, whereby the maximum constraint is at the leaflet tip level rather than at the annular level. These valves are extremely fibrotic, and they behave very much like the instant restenotic lesions in coronary interventions, and they're extremely slippery. And therefore, even though the perimeter on CT scan was 84 millimeter, which comes bang in the middle of 34 millimeter range, my initial impression was to go with 29 millimeter Evolute Pro valve, also because she was barely 5 feet tall. And therefore, the decision was that we'll decide whether to go for 29 millimeter Evolute Pro or a 34 millimeter Evolute R after the aortogram and predilatation with 25 millimeter balloon. And the behavior of balloon while predilatation will give us a clue about the appropriate size of the TAVI valve. The other important aspect in this case is regarding the aortomitral distance I described briefly in my previous slides. And I feel that a minimum 5 millimeter distance is a must to safely implant a TAVI prosthesis, whether it's balloon expandable or self-expanding, if you have a mechanical mitral prosthesis. Now, some operators feel that a distance of 7 to 8 millimeter is a prerequisite, but I think this can be stretched to 5 millimeter with some appropriate planning. So I'll show you what happened during the predilatation. So I understand that the balloon in the initial predilatation is quite ventricular, but if you see that the balloon actually slips and melancees forward once it's gripped the aortic valve. And what this suggests is that this valve, as I mentioned previously, is quite fibrotic. And the constraint you can see here in the other video is actually at the leaflet tip level. Just at the top margin of the pigtail, you can see the balloon is constrained at that point rather than at the annular level. And therefore, considering the experience with bicuspid valve sizing, it's safe that we can easily undersize these valves without the risk of paravalvular leak. And therefore, we opted for 29 millimeter Evolute Pro, also because this has the additional advantage of an outer skirt. So all these aortograms are now in cusp overlay views. So this is after the initial flaring of the TAVI valve. And you can see that we can easily make out the distance from the mechanical mitral prosthesis. The depth looks good here. And the second video is after deploying the valve to its 80%. Now, this is the advantage of this system, that if the operator is not happy at this position, if you feel that the TAVI stent frame is interfering with the mechanical mitral valve, you can easily recapture this valve and deploy it again. Thankfully, in our case, we got the desired result on our first attempt. So here the depth looks pretty good. It's around +3 or +4 millimeter. The mechanical mitral valve can be seen functioning well. There's hardly any aortic regurgitation. And therefore, we decided to release this valve. Now, I apologize that this video is going to be slightly longer, but this also emphasizes that I usually release as well as deploy these valves under controlled pacing very slowly. And you will see here that the entire process of releasing is being done in an extremely slow and controlled manner with pacing at around 120. The terminal phase of the deployment, when the valve is getting released, this is done under rapid pacing so that there is minimal movement of the valve during this point. And finally, this was the final result. So you've got an aortogram which is coplanar on the left side. You can see the native leaflets as well. They're extremely thickened. And you can now understand why the constraint is maximum at this level, unlike the degenerative aortic stenosis patients. There's trivial paravalvular leak closure just below left coronary cusp. The mechanical mitral prosthesis is working well. The coronaries are flowing well. The video on the right side shows aortogram in the cusp overlay view, again showing fairly good result, and an appropriately sized valve. So you can see that the valve is hugging the ascending aorta, and clearly a 34 millimeter valve would be an oversize for this. And this shows that even though the CT showed that the valve was bang in the middle of 34 millimeter, in certain scenarios, you have to look at the other parameters as well. So the take-home message from this case would be that one can easily treat rheumatic aortic stenosis with TAVI, albeit with proper planning. TAVI can be done safely in presence of mechanical mitral valve prosthesis, and this holds true for both balloon expandable as well as for self-expanding TAVI. In complex cases, the choice of TAVI prosthesis and the size of TAVI prosthesis should be based on CT findings on patient's anatomical features, body habitus, as well as the behavior of balloon during pre-dilatation. Now, normally we don't pre-dilate our valves routinely, but in complex cases where we are unsure about the size, we often take cue from the balloon dilatation. And I know that it's not a very scientific or robust way of assessing the size, but it does give you some important information. So control pacing is extremely important, even while deploying self-expanding prosthesis. Thank you. Thank you.
Thank you very much. We have, unfortunately, we have no time for discussion. So we're going to move on to the next presenters, Dr. Ivan Ma Ho Won from Hong Kong, China. His paper entitled "The Antegrade Retrograde Technique Applied in Uncrossable Transcatheter Aortic Valve-in-Valve Procedure." Dr. Wong, please start.
Yes, hi. So this is Ivan Wong from Hong Kong. So the topic is a transcatheter valve-in-valve procedure with uncrossable valve prosthesis. So I have nothing to disclose. And so let's take a look of the background of the patient. So our patient is a 73-year-old lady with a history of a surgical aortic valve replacement 10 years ago. At that time, is a perimount 21, so with a true internal diameter of 19 millimeters. So this time, she now presents with a symptomatic severe structural valve deterioration with a stenosis of the valve prosthesis. So this is the latest echo showing that there is a very high transprosthesis gradient across the valve prosthesis. And we also did a baseline CT for this patient. So as we can see in the left panel, there is a very calcified valve prosthetic leaflets. And on the right panel, we can see that there is an adequate virtual transcatheter heart valve to coronary distance to the both coronaries. So our plan for this patient would be a valve-in-valve procedure with an FR transcatheter heart valve with a 23 millimeter size. Well, we'll do the procedure under local anesthesia with a cerebral embolic protection device. So, and after assessing the patient with vascular access, we try to cross the valve. But however, at this particular point, we have repeated attempts with many different catheters and guide wires, and even try with the coronary guide wires. But unfortunately, all of these gears fail to cross these very severely stenotic surgical valve prosthesis with a prolonged procedural time. So at this point, so what to do? So what should be the next steps? We bear in mind that this patient, this procedure indeed was done under local anesthesia. So after the discussion with our colleagues, so we planned to switch to the Antegrade transeptal approach in view of these uncrossable valve prosthesis. So we use the ICE, the intracardiac echo, to guide the transeptal puncture to guarantee a safe procedure. So after gaining a transeptal puncture, we exchange the sheath to the highly steerable Agilis introducer. And through this Agilis introducer, we introduce the pigtail catheter across the mitral valve into the left ventricle. And so after putting the pigtail in the left ventricle, we can cross rather smoothly, antegrading across the valve prosthesis with a standard exchange J wire. So after crossing the bowel prosthesis, so we try to snare the exchange JY with a gooseneck snare in the descending aorta, which the gooseneck snare was introduced from the right femoral artery. So after snaring and externalization of the JY, so we form a VA loop. So, and as you know, so just a brief summary. So we switch to the transeptal antegrade approach, and we introduce the agilis introducer through the transeptal puncture, and then the pigtail into the left ventricle, and then the standard exchange JY across the surgical bowel prosthesis, and then we snare it in the descending aorta from the right femoral artery. So that's how we form a VA loop. So, and as you know, after forming the VA loop, which is an extremely good support, so we can introduce smoothly the pigtail catheter from the right femoral artery, just like a standard Tavi procedure. So after introducing this pigtail catheter, we can then remove the antegrade gears like the antegrade pigtail or the antegrade guide wire. So, and then we can switch back to a rather standardized normal Tavi procedure. So, and in view of this stenosis, we can predilate with a true balloon. And this video just want to show you that it is also extremely, as you can see, difficult to cross with 80 millimeters true balloon. So, and this again showed how stenotic the bowel prosthetic valve is. So, and after the predilatation with the balloon, of course, then the crossing of the transcatheter heart valve, the FVL, will be rather smooth across this bowel prosthesis. So after the placement of this transcatheter heart valve, we will further post-dilate with a true balloon. We use a 20 millimeter true balloon, which is indeed a true internal diameter +1. So in order to post-dilate and to have a satisfactory transcatheter heart valve function. So, and this is the final aortic root injection. So there are a few things we can see. So first, there is no significant aortic regurgitation we can see. And second, there is adequate coronary blood flow to both coronary arteries. And thirdly, the position of the transcatheter heart valve is excellent in relative to the position of the surgical bowel prosthesis. And we also did the invasive hemodynamic assessment, which showed there is no any residue transvalvular gradient. So indeed, I hope that this case can show you that even though many times the crossing of the aortic valve or the aortic bowel prosthesis would not be an issue, but indeed the antegrade transeptal approach would always be a bailout solution, particularly in these very challenging valve-in-valve procedures. Thank you for your attention.
Thank you very much, Dr. Wong. I think that is a very good idea to such a case using antegrade via manipulation. So we have almost 2 minutes for discussion. Does anyone?
Yes, may I ask a question?
Yes, please.
Yes, this is Dr. Cheng from Hong Kong. So, Dr. Wong, is there any precaution when you do the transeptal antegrade aortic valve crossing? And what is the downside of that?
Yes, thanks, Boris. Yeah, indeed, and we emphasize that this is the procedure is done under local anesthesia. So to make sure that it's a very safe transeptal procedure, we always recommend that the transeptal puncture should be guided by any form of the echo. So in this case, we use the intracardiac echo, which is also introduced from the femoral venous side, to ensure that it's a safe transeptal crossing. And after the crossing, indeed, I would say the usage of the steerable introducer. For example, in this case, we use the agilis introducer, which is also highly steerable. In order for the crossing of the mitral valve, we use only the pigtail catheter instead of any other guide wire to ensure that it's also a safe crossing of the mitral valve. So for these few things, I guess, would highly ensure that our antegrade transeptal approach would be the safest way to do that. Yeah.
Thank you. Any other question?
Thank you. And Dr. Wong, do you see any downside of using the the transeptal antegrade approach?
Yeah, of course. The downside would be
the wide cross.
Yeah, thanks, Dr. Chen. Yeah, of course, the downside would be there must be also a higher complication rate because of the transeptal puncture, and also and another point is if after forming the VA loop, there would be, for example, some tension or increased risk of the laceration of the cardiac chambers. So after crossing of the retrograde pigtail catheter in our case, we quickly remove all the antegrade like catheters or guide wire and to remove the VA loop in order to minimize this risk as well.
Is there any particular catheter you prefer after crossing the mitral valve and which you can help to steer your wire to cross the aortic valve, or you just use the pigtail?
Yeah, in this case, we try with the pigtail. Luckily, the pigtail and the J wire can cross. But in difficult cases, of course, you can use more angulated catheters, for example, like the IM catheter or like the Judkins Wright catheter will also work, I guess. Yeah.
Okay, thank you.
Thanks.
Great. Thank you very much. So we're going to move on to the next presentation. Next presenter will be the Dr. Rajaram Anantharam from India. And title of his presentation will be transcatheter closure of a large post-ventral ascending aorta pseudoaneurysm. Dr. Anantharam, please start.
Good. Thank you, sir. Thank you very much. Now, this is an interesting case of a transcatheter closure of a large post-ventral ascending aortic pseudoaneurysm. No potential conflict of interest. Now, the discussion points in this will be mainly, obviously, the post-ventral anastomotic leak, especially the distal anastomotic leak, is rare, but it is a serious life-threatening complication when it happens. Endovascular repairs with stent graft need adequate landing zone in these patients if you are going for endovascular stent grafts. And also you probably will need protecting side branches in those situations. Redo surgery in these patients again carries a very high mortality and morbidity risk. So in centers with adequate expertise, a device closure can be a lower risk alternative, as we will show in this case. And it needs a very good heart team discussion, good imaging, good planning before we take on the procedure. So it's a 44-year-old male, hypertensive, diagnosed with a severe aortic regurgitation, ascending aortic aneurysm, July 2012. He underwent Bentall's procedure with the composite 23 mm St. Jude's mechanical valve with the 26 collagen-coated Dacron graft. He was asymptomatic for a period of time. Then he presented again with some pain, and this is the transthoracic echo. As you can see, this is the tube graft, and there's a huge aneurysm below that. And this is the aneurysmal part, that is the arch. So it is this is your Dacron graft, and this is your aneurysm just between the left atrium and the Dacron graft. Now, transesophageal echo. You can see the continuing flow with the smoke appearance, spontaneous echo contrast. It was measured 5 by 5 by 7.5, so huge. And you can see the flow. Again, this image again shows that is your tube graft, that is your left atrium, mitral valve, left ventricle, and interposed is a huge pseudoaneurysm. And another image of the transesophageal echo, a spontaneous echo contrast with continuing flow into that. And this was continuing to dilate, and it was measured around 7.5 to 8 centimeters. And that is your tube graft with the valve here. So this is your true lumen, that is your Dacron graft. This is a large pseudoaneurysm, and that's about 17 to 18 millimeters mouth of that where it is shunting. CT as well as MRI was done, and the images clearly depicts what the problem is. That is your original Dacron graft. There is a mouth of about 18 millimeters and a huge pseudoaneurysm on the posterior aspect. of this tube graft and on the distal anastomotic site. So after a good heart team discussion, it was decided for a device closure, a right femoral access, and initially a 6 French, and the iotogram shows the posterior aspect with the leak. So it was upsized to 10 French, and a 10 French amplet sheath was placed over a amplet superstiff guide wire. And after measuring the mouth of the pseudoaneurysm, both by transcatheter echo as well as by the previous CT and MRI, it was decided for a 24 millimeter ASD septal occluder. You can see the distal disc there and the proximal disc now. Before deployment, almost near total occlusion of that with no flow across. Now it just flow is only through the tube graft and there is no flow into the pseudoaneurysm. Now 6 months down the line, there is no flow at all and it's shrinking and is asymptomatic now. So this is a rare case of a large ascending aortic pseudoaneurysm due to distal anastomotic leak 7 years after Bentall procedure. Endovascular stent graft will require satisfactory landing zones for anchoring as well as side branch protections. Redo surgeries are always associated with high morbidity and mortality. Hence, a device closure was considered. And there's been a few case reports of the device closure in thoracic and abdominal aorta. This is the first successful case of device closure in a post-Bentall ascending aortic pseudoaneurysm. And I sincerely thank the organizers for this opportunity.
Thank you very much for presenting the great case. I have one question. Did the patient have any infection at the site of pseudoaneurysm?
Sorry, sir, any?
Infection,
no,
yes.
No, there is no infections and ESR,
no bacteremia?
Nothing, no.
Okay, thank you. So, does anyone have a question or discussion?
Yeah, I have a question from Taiwan.
Hello, sir.
I am Dr. Lee from Taiwan, and what is your sizing strategy, and why do you choose the SD occluder? Because sometimes we use ADR or vascular plug. And is any idea you use the SD occluder?
No, the sizing we have had with both the CT MRI as well as with the transcatheter echo, it was coming around 18 millimeters. And it's only a very thin kind of interposing membrane between. So ASD occluder will be a perfect choice with the two large discs on either side rather than an AVP, because that might sort of fill up. You need good holding on either sides. That is one of the reasons. And the size is around 18. So that kind of worked well for this.
Do you use the multi-slide CT for sizing or just use the transthoracic echo and the TEE?
Both, sir, both. He had a pre-procedure, he had MRI as well as CT both. And during the procedure, he had a 3D transcatheter echo as well. So the TE was more of use rather than the CT, because the TE showed a realistic kind of the size as well as the 3D was helpful. And both of them kind of confirmed it is around 18 millimeters, 18 to 19. There was no major difference between both images.
Okay, thank you.
Thank you. Any other questions and discussion? All right, so we're going to move on to the next presentation. Dr. Chen, please introduce.
The next presentation is a successful transfemoral Tavi using Sapien 3 for bicuspid aortic valve stenosis by Dr. Tomonobu Yanesi from the University of Tokyo Hospital, Japan.
Yeah, it's a pleasure to present our case. I have none to declare. So the patient is a 68 years old man who had been followed up for severe AS with bicuspid valve. He presented with melena and anemia, and small bowel tumor with bleeding was found. So he required early surgery to the tumor. Then we planned TAVR before the surgery. So he was immunosuppressed on prednisone and cyclosporine for Harada disease. He had hypertension and diabetes and underwent PCI for effort angina 2 years before. He was relatively small in size and he had visual defects because of Harada disease. But otherwise, he had no physical or cognitive impairment. He showed dyspnea for NYHA class 2 without angina or syncope. ECG showed normal sinus rhythm, and laboratory data showed anemia and mildly impaired renal function. Diabetes was well controlled. STS score was calculated to be 3.7%. Transthoracic echography showed normal contraction and severe AS with trivial aortic regurgitation. Angiography showed no significant stenosis, including the stent sites in LAD. He had type 0 bicuspid valve. The area of the aortic annulus was 440.7 millimeters square. The area of 4 millimeter above the annulus was 410.8 millimeters square. The diameter of the ST junction was 25.7 millimeters. The calcification was only mild. The aorta was not dilated, and LVOT had a calcification at 5 o'clock. The coronary arteries were high enough for TAVR. The aortic angle was 50 degrees. The peripheral vasculature was not tortuous, so was suitable for transfemoral approach. So based on these findings, we went for a transfemoral TAVR. So he was 68 years old and he was young, but surgical AVR was deemed high risk because of bleeding from the small bowel tumor and the immunosuppressed condition. So he had type 0 bicuspid valve, classified as almost tapered configuration according to the VALVES registry. We selected SAPIENS 3, considering the future possibility of TAV in TAV and better coronary access because of his age and past history of PCI. The area was between 23 and 26 millimeters of SAPIENS 3, considering the tapered configuration and higher risk of under-expansion or aortic root rupture in bicuspid cases, we selected 23 millimeters of SAPIENS 3 rather than underfilling of 26 millimeters. This is our strategy. We usually conduct TAVR under general anesthesia. Direct TAVR as usual with SAPIENS 3. We use lucent line technique to guide the valve position to reduce the risk of pacemaker, especially concerning his age and immunosuppressed condition. So this is the actual procedure. SAPIENS 3 cross the native valve without predilatation. Then we moved on to the lucent line technique. In the left picture, the usual perpendicular view, the lucent line couldn't see clearly. Then in the right picture, this view made the lucent line visualized clearly. Because this view was perpendicular to SAPIENS 3, so gotten by moving the angulation caudally. Then we align the lucent line with the bottom of the cusp, and under rapid pacing, we deploy SAPIENS 3 at nominal pressure with slow inflation. This lucent line technique can achieve smaller implant depths and reduce the risk of conduction impairment. So after the implantation, the patient remained sinus rhythm. Sapien 3 was implanted in the optimal position with just trivial paravalvular leakage. CT showed the optimal expansion of Sapien 3, which was really circular. The implant depth was 1.5 millimeters. He was discharged 4 days after the operation as scheduled. This is our usual time course. His ECG has not changed, no conduction abnormalities. The mean pressure gradient improved to 16 millimeters mercury with trivial PVL. He underwent a laparoscopic surgery to the small bore tumor 3 weeks after the TAVR. So this is the summary. This case is a successful case of TAVR for type 0 bicuspid valve with high implantation. The number of TAVR for bicuspid valve is expected to increase, but on the other hand, TAVR for bicuspid valve is still challenging. With careful CT planning, Sapien 3 is useful for bicuspid valve patients. Lucent line technique is known to reduce the risk of permanent pacemaker without compromising safety or outcomes. Thank you for your attention.
Okay.
Yeah, maybe hi, I have one question. So this is Ivan from Hong Kong. Yeah, so thanks for the presentation. I just want to ask you for the lucent line technique. So you mentioned that you would achieve a higher implantation depth, right? But for the Sapien 3, how would you comment? There is also another technique from the Cleveland Clinic about the cups overlap. So usually they would use the RAO caudal wheel and with also the lucent line trying to place at a higher implantation depth. So would you, how would you comment on this RAO caudal implantation technique?
Sorry, I couldn't catch your question.
Yeah, from the Cleveland Clinic, they advocate the implantation of the Sapien 3 at what we call the cups overlap technique. So which is usually in the RAO caudal projection. So how would you comment on this compared to your lucent line technique? Yeah.
So in lucent line technique, the perpendicular to Sapien 3 view is the necessary to positioning, and in this case, bicuspid valve. So the cusp overlap view is
maybe difficult. Yeah. Yeah, I know. So for example, not in this case, like in the tricuspid valve usual cases, because for example, in the RAO caudal wheel, what we agree is that maybe the true implantation depth or like the LVOT is elongated, so it's maybe a better assessment of the true implantation depth. So I just want to see how is your view on this technique. Yeah. Yeah, but it's okay. But of course, yeah. For this, I just want to say is for this, even for the Sapien 3, so there is even now more and more groups try to advocate the use of the cups overlap wheel, which also would result in a high implantation depth. Yeah. Okay. Yeah. Thanks.
Thank you for your question.
I also got one question for you. How was the antithrombotic therapy after TAVR in this case? Because this patient is hybrid in this patient. So how did you manage for the antithrombotic therapy after TAVR?
Oh, thank you for your question. Because he underwent PCI, he used aspirin single antiplatelet therapy, and after TAVR, he only aspirin only.
Doesn't use the clopidogrel?
No.
Okay. Okay, thank you.
Okay, is there any more question from the floor? If no, we move to the next presentation, Bicaval valve implantation. The presenter is Dr. VALVES.
Okay.
So good afternoon, everyone. And at the outset, I'd like to thank the organizers for giving me this opportunity. I have nothing to disclose. My mentor, Dr. Kamath, because of whom I am here. These are discussion points of this presentation is the pre-operative assessment, the procedural steps, post-operative management, and the take-home message. Our patient was a 72-year-old male, presented with a history of shortness of breath of progressive nature, and his pre-procedural diagnosis was isolated organic severe tricuspid regurgitation with a mild RV dysfunction and a mild PH. He also had chronic atrial fibrillation with a controlled ventricular rate, an insignificant coronary artery disease, a chronic kidney disease stage 3B, a chronic liver disease of child A, anemia due to blood loss, as well as chronic disease, hypothyroidism. He also had intolerance to oral anticoagulation and hyponatremia due to diuretics. This is how his echocardiogram looked. His adequate LV function and a humongously dilated RA with a mild RV dysfunction, a torrential tricuspid regurgitation, and a dilated congested IVC. This is how the TAPSE was pre-procedural. 1.4 when he initiated the procedure, the patient 6 months prior to this, his TAPSE was around 12. This is how the MRI looked, cardiac MR, which shows humongously dilated RA with a severe TR and adequate RV function and an adequate LV function. A right heart cath was performed, which showed a systolic pressure of 50 millimeters of mercury, elevated RA pressure, and RV angiogram showed no RV apical obliteration and adequate RV function. The CT scan was performed, the MDCT, to delineate the SVC and IVC and to measure the exact sizing for the SVC and IVC valves. The contraindications for Bicaval valve are RV dysfunction with a TAPSE of less than 13, a pulmonary artery pressure of more than 65, systolic, a bleeding diathesis, significant untreated left-sided valve disease requiring treatment, a recent CVA or acute coronary syndrome, or severe LV dysfunction, or a chronic liver disease of child C. The case was discussed with the heart team meeting and was accepted for a high-risk surgical repair of tricuspid valve. The hematology consultation was done because the patient had chronic anemia and their advice was followed. The patient was doing all well prior to surgery when he developed massive hematemesis and presented to the ER. His hemoglobin was 5.4 at that point of time. Upper GI scopy was performed, which shows an active duodenal ulcer and grade 2 esophageal varices. His DOVAC was stopped and a standard treatment for duodenal ulcer was done and followed by esophageal varices ligation since the patient had to be on lifetime oral anticoagulation. The surgical intervention was ruled out as patient had multiple comorbidities and the patient was prepared for percutaneous bicaval valve implantation. The challenges which we were going to face at this point of time was a chronic AFib and a bioprosthesis, which requires a lifetime oral anticoagulation. He also had bleeding diathesis in the form of hemoptysis and hematemesis. He also had a chronic anemia. He has cirrhosis of liver with esophageal varices, which was ligated at present. He also had hyponatremia on diuretics, and the choice of oral anticoagulation post-implant was another issue. This is how the SVC and IVC valve looks. The SVC valve has a belly and IVC valve is a funnel-shaped valve with the skirt and a valve. The valve is a bovine pericardial valve. On the day of procedure, the patient was mechanically ventilated and TE probe was placed in situ. Bilateral femoral venous access was taken, an arterial line to monitor the blood pressure continuously. The intravenous heparin was given to maintain an ACT of more than 250 seconds. Since the delivery system is about 26 French, we had to do a surgical cut down and it was done with the help of a surgeons. A pigtail was placed in the RPA to mark the crossing of RPA with the SVC. This is the most important landmark in this particular procedure, following which an SVC angiogram was performed to delineate the confluence as well as the SVC RA junction the pigtail was removed and a thermo wire was placed into the RA curling round to mark the roof of RA to place the SVC valve. Following a cut down and placing a super stiff amplats wire into the SVC, the delivery system with the SVC valve was loaded on the super stiff amplats wire and was placed at the confluence. The upper part was kept at the confluence. With the help of TEE as well as on the fluoroscopy, the valve was placed with the belly of the valve just above the RPA crossing. With the help of a venogram taken from the right brachial, the valve position was reconfirmed and the upper part of the valve was unloaded, following which a reconfirming of the position and the valve was deployed in a continuous and a smooth fashion so as there is no jerky movements. After which the delivery system was removed, retaining the amplats wire, and a IVC valve was loaded and kept at the height of the diaphragm. At this point of time, a multipurpose catheter was taken and a hepatic venogram was done to look at the skirt of the valve, which is seen as a hyperechoic thing here, so that it does not obstruct the hepatic venous inflow. With the help of TEE, the margins of the valve was aligned with the IVC-RA junction so as it is not too high to prevent paravalvular leak or it's not so low to prevent a hepatic venous obstruction. Following which, the valve was delivered in a smooth fashion by looking at the distal edge so as it doesn't have any jerky movements to prevent malpositioning of the valve. This is how it looks post-implant. With an RA angiogram was performed to look for any paravalvular leak in the IVC. This is how the TE looks in a bicaval view with both valves in position, moving well. The post-implant, the patient went on enoxaparin 0.3 subcutaneous for 6 months. However, the recommendation is first 3 months vitamin K oral anticoagulation. Since this patient had hemoptysis with oral anticoagulation of vitamin K, both with acetrom and warfarin, patient could not tolerate this particular molecule. So we had to give 0.3 subcutaneous for 3 months. However, this patient had a spontaneous left knee hemarthrosis and subsequently left elbow after a fall hematoma. So he had to be continued on 0.3 SC for another 3 months. Following which he was started on a Dovac rivaroxaban 15 milligram OD. He had no hyponatremia, fortunately, since he had almost nil diuretic and his hemoglobin was stable, almost 9 to 10 with no bleeding. At 1 year of follow-up on June 5th, a patient doing well, able to do all his normal activities at ease. He had no admissions for cardiac-related issues. He had no hemoptysis, hematomesis, and he had biventricular function with a normally functioning valve. This is how the valve looks. You can see that the TR has almost reduced with adequate biventricular function. To conclude, a take-home message is clinical identification of significant TR is most challenging owing to its silent nature. Significant TR has a negative effect on long-term outcome of clinical outcome. Management of patients with TR is complex and surgical treatment remains the standard of care but continues to have the highest mortality among all cardiac valve related procedures. In selected patient, percutaneous tricuspid valve repair or a bicaval valve implantation can provide a new lease of life to patients with much less mortality compared to surgical treatment. Thank you very much. These are my parents, because of whom I am here today. Thank you.
Is there any question from the floor?
Okay, I have a short question. So, and I think this is a very interesting and educational case. I have one question about the long-term durability. Do you have how many patients treated with bicaval valve implantation? How do you expect a long-term durability of this, novel technique for bicaval implantation?
This is one of our case which we have done an implantation. We have a follow-up of only 1 year and the patient is doing extremely well. This patient presented to us with an anasaka with a huge scrotal swelling which you will not believe, which was humongous. It was like a basketball. We had to treat him and bring him down to this nature to treat this patient. And I am extremely happy with this particular case because in the last 1 year, this patient did not have a single admission for cardiac related issues. And prior to this, in the last 6 months when we prepared, this patient has almost every month into the hospital with a cardiac failure symptom. So that way it is. Worldwide, there is around 450 implants which has been performed and almost all of them are doing very well with almost nearly 5-year follow-up.
Great.
Yes, Dr. Brandes. So is the SVC valve or the IVC valve repositionable?
I didn't get you.
So, whether the valve is repositionable. So
the positioning of the valve.
Yeah, if the position of the valve is not nice, can we change the position?
No, we can see for the SVC valve, the first 20 millimeters can be retrieved. The first 20. Once you deploy that, you cannot do anything. That's the very tricky position. We cannot do. That's the reason why we say it's a margin of error is just 5 millimeter for IVC. And if you deploy it once, it cannot be retrieved. This is the most dangerous thing. You have to be extremely careful. You have to continue praying to God every millisecond. I will not say second when you deploy this, because once you deploy, it's all over. You can't do anything. We cannot retrieve it. Only the SVC has a small mileage because the first 20 millimeter can be repositioned once you deploy the first 20 millimeter.
Oh, understood.
So what happens to the RA mean pressure after this valve implantation? Because I suspect the tricuspid regurgitation would still continue. So the RA pressure would go up. And does it affect the coronary inflow then?
The RA pressure definitely goes up immediate post-implant. And it's found that at the end of 6 months, the RA pressures come down over a period of time. However, we have not done a cath measurement in this particular patient after the implant, but the studies have all shown worldwide that the RA pressure initially increases post implant, and by the end of 6 months it decreases significantly to normal. And our TR pressure, which we have recorded, has shown that it has decreased to a mild extent. The pressures which we recorded was around 50 millimeters, which has come to around 32 right now.
So can you explain how the RA pressure comes down? Because the tricuspid regurgitation would never decrease after putting the...
Definitely, the congestion definitely decreases because you have both the valves on both ends, SVC and IVC.
I'm not asking about congestion. I was just asking about the mechanism of how the RA pressure comes down after 6 months.
See, your dilatation comes down, your RA, the load into the RA and RV definitely comes down once you have a valve in, because you don't have a free flow now inside the RA and RV.
But the tricuspid regurgitation will still continue.
Will not.
So because of the limitation of time, maybe we leave the discussion in the chat group, okay? So we go to the next presentation.
Thank you.
Yeah, thank you. So the next presentation is a tight squeeze, preserving effective orifice area in Tavi on Percival, valve in valve. The presenter is Dr. Wen Fei So Bin Wang Wahimi Shah from Institution Jantung Negara, Malaysia. Dr. Wen.
It's always difficult to become the last presenter once you have seen all these amazing cases. It's just for me. The reason I send this to share with the others is just to showcase what we have done in our center. So, as a title is a tight squeeze, preserving effective orifice area in Tavi on perceivable valve in valve. for me, Dr. Wan Faisal, on behalf of my colleagues. So I have nothing to disclose. So the patient characteristic is a 75 years old lady. Again, she's a small lady like all our Asian females. Body surface area is only 1.47. So she already have conduction system disease, so bifascicular block, first degree and right bundle. And she also has incidental subclinical hypothyroidism. Now, she came to our emergency with recurring breathless just recently in December. And at that time, she was NYHA class 2 and exhibits symptoms of failure. Now, this is the cardiac history of the patient. Now, she had prior aortic valve stenosis and ischemic heart disease. Now, also, she had also underwent a PCI to the LED done in 2003. Now, when she was diagnosed with severe aortic stenosis, she was well at that time. And she had underwent a surgical aortic valve replacement. Now, because of a small lady, the surgeon has chosen a sutureless bioprosthetic perceivable valve for implantation. Just for the benefit of audience who haven't seen perceivable valve, this is what the valve looks on the X-ray. As you can see there, this is the X-ray with the superimposed 19 frame, which is this valve, which is a bovine valve, which is fixed on the self-expanding 19. So echocardiography at the point of admission for failure definitely shows this evidence to suggest structural valve degeneration of the bioprosthesis. The mean gradient is high for 51, the max even higher, 75. And also there's presence of mild to moderate aortic irritation. And EF is still preserved, 51%. So this is what the echo looks like. I mean, I think it's clear cut to everyone that the valve has degenerated. And then taking the gradient from the 5-chamber view, we got a velocity of roughly above 4 centimeters per second. So I think that's clear cut in terms of diagnosis. Now, we did an angiogram for her. Now, deliver the progression of the disease compared to the single vessel disease that she had before. She had RSL of the mid LD of 95%. And de novo lesions in the mid circumflex and mid RC. I know this is a bit offset from our discussion of the valve, but just want to tell that we have intervened on all vessels prior to the transcatheter heart valve implantation. So the LED was stented with DS 3.0, RC similar 3.0, while the circumflex was the balloon with drug cotton balloon 2.75 times 20. Okay, so this is what it looks like pre-angiogram of the LED. After stenting on the right hand side. Similarly, this is the circumflex. You can see there's a new lesion in the mid. And this was the final result after drug cotton balloon. Again, the result looked very nice. And this is the RC. As you can see, it is difficult to cross the valve, cross the 19 frame with your catheter, but we managed to do that successfully for intervention as well. Even look at that difficult angle. So after the multidisciplinary team meeting, we have decided that she needs a Tavi implantation. At that point of time, the plan was to utilize a new balloon expandable transcatheter heart valve MyVal, which in our institution is the first such use for valve-in-valve procedure. Now, the main drivers for use of this particular valve is cost. Okay, the company seemed to have able to bring down cost. Again, we wanted to choose a balloon expandable device. And one of the things that we find very enticing is the 14 French introducer system, which is much smaller than its contemporaries. So this is the design of the valve. Similarly, I think it looks quite similar like the Sapien 3 valve. Half of it, the upper half is the cells, which is quite big. And there's an external and internal pad skirting to reduce valvular leakage, and a cobalt alloy frame with bovine pericardium tri-leaflet valve mounted on this frame. Now again, this for benefit others who haven't used this valve system, the delivery system is much more simpler in terms of, I won't dwell too much into how it performs, but again, one of the draw of this valve is the Python expandable introducer sheath. Now the thing is that for this valve, as it enters into the sheath expands a little to allow the passage of the valve, but it returns back to its 14 French diameter once the valve itself has passed through the sheath. Okay, this is an analysis of core lab of our patient using 3 Mencho, their proprietary system. So nothing much to say here, just the perimeter is about 64, the perimeter derived area is about 20.5. But I'll show you the analysis is a bit elliptical, not completely circular. And then the left cornea height is slightly shallow compared to the right side. So looking at the parameters, I mean, the interesting part of the MyVal is that we can use the sizing in between, like 20 to 20, we have got a size 21.5. So that gives you a bit of flexibility to decide which valves you want to use. Looking at the area derived diameter and parameter, we could use a 21.5, but we opted to use the 23 millimeter instead. Again, this is the picture of the annulus. Okay, I think you can appreciate it. It's a bit elliptical, and then the maximum diameter you can get up to 23 millimeter. Other parts, again, similar that I've talked to you before. This is the cornea height assessment, sinus of Bicaval measurement. Classification-wise, there is scattered classification, but again, I think it's not bad at all. The axis is more favorable on the left-hand side, a bit smaller compared to the right. But then there's not much tortuosity on the left-hand side. So we opted to use the left side for our main device delivery, and any adjunct devices comes from the right-hand side. So for this itself, now we're a bit traditional in our use. So we still use GA. Again, this is what we are used to. We are not a very high volume center in terms of Tavi. So it has been the norm for us years to use general anesthesia. I know there's a lot of other places which has gone all the way down to local sedation, but this is what we have done. Temporary pacing wire with right internal jugular vein. This is done much more easier in general anesthesia. And then the 2 6-branch artery access from the right femoral artery, one for the pigtail, one for the left coronary artery protection. And then left femoral artery access for delivery, exchange to a 14-branch Python shift, and the valve size that I mentioned before. This is the shift introduction. As you can see, the movement is very smooth, it's very fluid. And then this is the valve. As you can see, again, this valve, the shift need to expand the valve. So there will be some resistance as you wanted to expand. So it's not that particularly easy, okay? But then again, the clean valve can pass once you have the valve, the shift has expanded slightly to allow the passage of the transcatheter heart valve. Okay, now this is a sutureless valve. So again, I think the debate will range on whether you want to crack the valve or not, but we opted not to. Okay, and then this is the passage of the transcatheter heart valve. I know without cracking it's a bit more difficult. As you can see, the aorta is a bit horizontal here. By changing the orientation, then the valve can be able to pass to the stenotic and degenerated valve. This is delivery, okay, and this is the inflation of the valve across this bioprosthesis. So it went off pretty smoothly. We were happy regarding the valve implantation height. And this is the final outflow injection, which shows the result is very nice with minimal paravalvular leakage. Now, the progress is that as we know that she has a background conduction system, so we expected that there will be issues regarding that. And then she developed occasional complete heart block. Thankfully, the temporary pacemaker was left in place. And then we opted to perform a CRT device implantation, okay, knowing that she has extensive conduction system disease. So she was discharged home after 2 weeks. The only issue is that there was a wound hematoma in the CRT site, which required evacuation in between. The echocardial follow-up, again, the result looks good. You can see there's a mild paravalvular leakage seen here in the long axis view. And the thing is that we're quite worried how much gradient that we can get from this one. I've read case reports that show that for perceivable valve, after Tavi, they tend to get higher mean gradients. So we can see here, measurement seems to be quite good, less than 15. We got about 12 millimeters mercury for our gradient across the valve. And these are just other images of what the valve looks like on echo. So the conclusion, this case depicts importance of maintaining aortic valve effective LFIs. I guess it's important for our small small size population, especially for females. The first attempt was by surgical method, in which they used a sutureless bioprosthetic valve. However, in this case, it suffered a structural valve degeneration, and then we utilized a size 23 millimeter balloon expandable valve for the procedure. And then for this particular procedure, we like the smaller interstitial sheath because of the small size lady. I guess nothing much for me. Is that discussion points is that I would like to throw to the moderators and everything regarding all these issues, corneal access, prosthetic gradient, patient prosthetic mismatch, whether it can adequately fixate or not in a perceivable valve. Because as far as I know, there are not many cases for valve involved for perceivable. So all of this, I guess we need a combination of all the expertise from all around the world. And for that, I would like to thank you for your attention.
So is there any question from the floor?
Yes, I have one question. This is Ivan from Hong Kong. Yeah, I can see there is, you have done the coronary protection during the MyValve implantation. So is there any reason for the coronary protection?
Thank you for your question. Now, I guess I think it's operator preference, I would say. I mean, in high volume centers, obviously, I think 16 is adequate to not needing protection. But again, whenever we use new devices, I guess precaution is paramount. So in some things where we are not really sure how the device may behave, and so I think probably taking safety measures, which is above and beyond, I think would be not to say a bad thing. So that's the reason why the corneal access was used. But then again, I guess you can see when the valve was implanted, again, the structure is well away from the left cornea. So I guess it was an the reason it was done in overabundance of caution, I would say.
Yes, thank you.
Okay, if there's no more question, Dr. Lobo, do you have any concluding remark? So,
Okay.
so I would like to say thank you to all the presenter, and we have seen some good cases for the Tavi, different aspects, and some innovative device like the Bicaval valve, and also the innovative culture of a pseudo-aneurysm post-bento operation. And I would like to congratulate to all the presenter. And hopefully in 2022, we can meet in real life and face-to-face meeting. Thank you.
Thank you very much, guys.
Thanks. Bye.